Well, good afternoon, Facebook, and welcome to another episode of You've Got the Power. I'm your host, Dr. Jason Deitch, and of course, we're here with the great Dr. Chris Centeno. Dr. Centeno, good afternoon.
Good afternoon, Jason.
For those of you that are new to our program, Dr. Centeno is the founder and medical director of the Centeno Schultz Clinic, as well as the founder of the Regenexx affiliate network of expert regenerative orthopedists around the world who are here, ready, willing, and able to help you with things like today's topic, low back pain, specifically disc bulges, alternative ways to address this. That's what today's program's all about. And before we get into describing all of that, just a few things. If you are new to this program, if you would like help, you'll see in the comments there are two ways to get help. One is to type the word HELP down in the comments below. That'll get you a free copy of the Spine Owner's Manual, where you can read and learn from Dr. Centeno's book he wrote all about what you need to know if you've got a spine, what you should have been given at birth about what you need to know about owning that spine and making sure it works well for your life. And two, if you're ready for some help, our phone number is down below. You can give us a call and either set up a telehealth consultation or a live one-on-one consultation in the office in Colorado. All right, with all that said, Dr. Centeno, good afternoon. Let's talk low back pain. Let's talk disc bulges. Let's start with what are disc bulges? What do people need to know about what they are and the symptoms they might be experiencing as a result of having one?
Yeah, Jason, so it's really interesting. We have these discs that act as cushions between our backbones or our vertebrae. And one of the problems is that we all kind of get, or most of us get, some disc bulges as we age. So the real question then becomes, some of us, those will never be a problem. And for some of us will have issues related to those disc bulges. Generally, when they start to irritate nerves, and so that means that the disc itself is bulging out and gets a little pooch on it, usually due to tears in the tough outer covering of the disc. And when that happens and it pisses off a nerve, then people tend to get symptoms. Now, sometimes it never pisses off a nerve, and people have disc bulges and they don't even know it. So it's really the symptomatic ones that we're talking about, things that are really causing patients problems. And what kind of problems? We're talking about pain in the low back, stuff down the leg. When I say stuff, that means some numbness, tingling, burning, or other that kind of stuff.
There's lots of different symptoms that can be a result. What's interesting about what you said, many people actually have disc bulges with no symptoms. And then there are people that have severe back pain and don't have bulging discs. It is sort of this, does it cause it? Does it not cause it? A lot of confusion. I guess that takes us into, let's talk about what are some of the common ways people approach it. People tend to sometimes want to ignore it. It's not that bad. It's not that bad. Oh my God, it's terrible. Or they go to their primary doctor and their primary doctor recommends traditional medical approaches. Let's go down that road first. What are the most likely recommendations somebody's going to get if they go to their general physician and they go, oh, it hurts. Yeah, every once in a while it sort of goes down my butt into my legs. Doc, what do I got? How do they normally follow up, and what do they normally recommend is when that happens?
Yeah, so if you go to your family physician, you'll get some non-steroidal anti-inflammatory drugs, Motrin, Aleve, those sorts of things, maybe a prescription for one, something like Celebrex. The biggest problem with those drugs is that they increase your risk for sudden death heart attack. So we try hard not to prescribe them on our side with what we do. But, they're commonly prescribed drugs, and you can pick them up in the grocery store. And if that doesn't work, the person will be sent to physical therapy, or sometimes they're sent directly to a chiropractor, or they will see a chiropractor. And then if that doesn't work, oral steroids are commonly prescribed. So them and some issues with them. And then if that doesn't work, usually an epidural steroid injection. That's where they inject steroids.
And that's what most people do expect. It's the most common forms of treatment of this type of condition. But I guess I'll ask, what's so bad about that? If it's the most popular, if it's recommended by my doctor, isn't the assumption that that's the best practice, that that's got the most science and research behind it, that that's what's most effective? Isn't it?
Yes and no. So listen, there are patients that get better with oral steroids. The biggest concern there is that there's a small risk of getting a very serious bone disease where your bones. There are other concerns now about increases in infection risk. There are other concerns with regard to other problems that steroids cause. So that's the issue there, is that while it can be a potent anti-inflammatory and can chill it out, those medications have pretty significant side effects. Then we go to epidural steroid injections, which is where high-dose steroids, same stuff really, around the nerve to try to calm down the local inflammation. And again, this problem there is that steroids tend to reduce the body's ability to heal naturally. In the area with a huge anti-inflammatory that has big side effects, and you could sometimes describe it maybe as using a can of a fly, which is a common statement made by Confucius many years ago, meaning that there are more elegant ways to kill a fly, but a cannon will work. It just has some collateral damage associated with it.
Yeah, and we're proud of going, see, the fly's dead, but we forget to look at all of the other consequences. We sometimes think, well, isn't that an interesting coincidence? It just got worse on its own. Not really recognizing that the traditional approach to many of these orthopedic conditions follow that exact philosophy, that it is chasing the symptom as opposed to really pausing for a moment, understanding how the body works, and really trying to address the underlying cause of the symptom, in this case, pain, sometimes radiating pain, and others. So if you're watching, have you ever had a bulging disc? If so, what did you do about it? And have you been to the Centeno Schultz Clinic? If you've had a positive experience you'd like to share, let us know down below. If you've got questions about your low back pain, specifically a bulging disc or a diagnosis that may include bulging disc, now's your time to ask. We're with Dr. Chris Centeno, founder of the Centeno Schultz Clinic in Colorado, who really for the past 15 plus years has pioneered the field of regenerative orthopedics, specifically orthobiologics. Let's get into it, as the title of today's program really is all about alternative ways to approach these types of conditions. So if we're not going to nuke it, if we're not going to, throw the bomb at the fly, what are some of those more elegant ways that we should consider?
Yeah, so listen, I've had a bulging disc in my back, so I know what that's like. And I've had both epidural injections, which is a little bit like a sugar high. You feel real good for a week or two, and then you crash. And I've also had regenerative injections. So that would be using the growth factors from my own blood platelets and injecting those around that irritated nerve and or into the associated ligaments or disc, etc. And it's a different experience just from a patient's perspective, because I was the patient. You tend to get relief over that first week or two, and then it lasts a lot longer. So that's a difference if you're doing the same type of injection, epidural steroids versus epidural platelet lysate, which is those platelet growth factors. And then there are other considerations as well. On the regenerative side, you can tighten down ligaments, you can go after muscles that are atrophied, you can go after joints that are getting beat up, et cetera, et cetera. So those are generally things you can't do with a steroid shot.
We got some questions. One that was submitted a bit earlier. Thank you for letting us know. This was submitted in advance by Sherry Wilson. She asked the question, my doctor wants to remove the disc. Is that a safe procedure to do, Doc? What are your thoughts on removing discs?
Yeah, listen, Shelley, I can't say it should never be done because there are a few patients that I see every year where it probably needs to be done. But the problem is we go to that solution much, much too quickly in far too many patients. So if you think about it, removing, when they say remove the disc, what they're really talking about usually is take the back part of the disc out, and that removes the back wall of the disc. And so once you do that, it doesn't really heal very well. So you're left with a disc that is a lot weaker, and meaning it's much more likely to herniate going forward. That's called a re-herniation. And so that's the biggest problem. I think what we're talking about is destroying the structure of the disc to try to take a part of the disc out. And the good news is that can take some immediate pressure or irritation off the nerve. The bad news is in the long run, it kind of weakens the disc and weakens the spine.
It's really one of the things as consumers we really have to pay attention to, and that is that you mentioned sugar high before. Feels good in the moment, but there's a hangover. There are consequences. There are physiological, in some cases, irreversible things that are happening as a consequence of that hopefully immediate, relief. All of this relief is referred to as temporary pain relief. So it's really essential, as we talk about here in this program, you've got the power. The reason why we call it that is because ultimately it is up to you to decide the right pathway to go down. Now, Doc, there's sometimes questions about cost, and people tend to sort of take the path of least financial resistance, or at least their perception of least financial resistance. So, when people hear, they go to their primary, sometimes they've waited days, weeks, maybe even months to get in. Maybe they were on a telehealth consult in these times, or maybe they took the risk to go on out and into either a hospital setting or a general medical center setting where there is multiple types of conditions. They get this recommendation. They go, is it covered? They go, yes. That seems like a good idea at the moment, but what is really the experience you had and other people have when they go through with a procedure that they think is covered, but oftentimes find that they're spending more on deductibles and co-payments, even when it's a covered service, than if they were to look and work directly with a doctor otherwise. What are your experience, and what are the things people need to be aware of?
Yeah, well, I think there's a couple layers to that question, or maybe the answer. The first is, as we all know, our insurance these days is not like it used to be. It used to be that you went into the doctor, something was covered by insurance, the insurance company took care of it, you maybe got something in the mail that explained what they paid, and you were done. Now it's not really the case at all. What we're seeing is massive copays, deductibles, co-insurance payments. We're seeing balanced billing come in where someone's not on the network, and then the patient gets nailed with a big surprise bill. So using your insurance company went from what it used to be, it costs you nothing, to it costs you a lot. And then you get into another thing I'd like to really discuss, because it's something that we as physicians see all the time, and as a consumer, you wouldn't notice it, but it's important for any business, right, to take in more than it pays out. I don't care if you're a doctor's office, a hospital, a for-profit hospital, a non-profit hospital, it doesn't make a difference. You still have to take in more than you pay out. Well, how do you do that in traditional medicine? Well, there's two different things you can do. One is you can treat on volume. So you want to basically move them in and move them out as quickly as you can because you get paid per click by person. Obviously, there's degradation in care when that happens. The other thing we tend to see is you tend to push patients toward procedures that compensate better from insurance companies. So as an example, we're talking about the low back, one that we've been really focused on. I focused on a couple times on the blog is SI joint fusion. Someone has an SI joint pain. There are cheap, inexpensive orthobiologic solutions to treat many of those patients. But most of those doctors don't want to do that because that doesn't put money in the hospital's coffers. So instead, they're pushing patients toward these new SI joint fusion devices, which pay quite well. The hospital gets a nice big fat operating room charge. Some company gets to sell a $10 screw for $2,000, and the doctor gets a nice fat procedural fee. Now, is that the best thing for that patient? It's not, but it's covered. So if you've got someone over the barrel, so to speak, as a doctor, of saying, well, it's covered, then you can frequently push them towards much more expensive, much more invasive care that reimburses much better for the doctor, but isn't the best thing for the patient. And that's what we see time and time again, contained within that phrase, it's covered.
It is almost hard to believe that, in a system with so many hardworking doctors who have sacrificed so much, studied so much, learned so much, student debt, family sacrifices, all that goes with it, that these, in many cases, great, hardworking, dedicated, service-oriented people could be in a system that actually is so financially motivated, where they're literally putting profits over people, which is what I'm hearing you say, that the system itself is designed so that there's maximum reimbursement for the hospital, for the doctor, not necessarily maximum benefit for the person. Am I interpreting that accurately, as hard as that is to believe for many of us? You go, but my doctor's great and I love my doctor and all the history and the well-intentioned things. Is that really the state of our system today?
Yeah, so Jason, again, I don't think it means that these doctors are evil or bad or anything. I think though that what ends up happening is that people will do what you incent them to do. It doesn't matter if you're a physician, doesn't matter if you're a carpenter or an air conditioning guy or an attorney. You're incented to do what pays the best. And the problem with things that are covered by insurance is that what those things tend to be are the most invasive things that we can offer. So, for instance, the insurance reimbursement is determined in part by invasiveness. If you've got a minimally invasive procedure, it tends to reimburse less. So something like an injection, versus if you've got a moderately invasive procedure, let's say taking out a portion of the disc, versus a fusion. So that invasiveness is built into the reimbursement component. So that then leaves the most invasive things we do as being the best reimbursed by insurance companies. And that's a real problem. It's not that those folks are bad or evil. It's just that they're tending to push patients towards things that they know will reimburse the best for their time. So I could do 5 of these procedures over here that takes 5 times as long, or I could do one of these procedures over here that takes a fifth or a fourth of the time and get paid 5 times as much. You don't have to be a rocket scientist or a human psychologist or anything like that to understand that people will gravitate towards what you incent them to do. And right now, that's what the system incents.
That is unfortunate, and that's why you have to take back your power. We've got a good question from our friend Andrew, a regular viewer. Asked the question, good afternoon again. Good afternoon, Andrew. He's asking, is PRP or stem cell more appropriate for a disc protrusion at L4, L5 that is causing pressure and pain at times? Thank you. What are your thoughts on Andrew's question?
Yeah, so Andrew, let's talk a little bit about discs so that everyone can learn here. So we have tears in discs, and a tear in a disc can cause the disc itself to be painful. That's often called discogenic. So that's one thing. And then we've got a bulging disc, which is where the disc kind of pooches out a little bit, and that can irritate a nerve. Then we've got a herniated disc when the inside stuff inside the disc squirts out. So if we look at bulging discs, in general, platelet-based treatments tend to work quite well for most patients. Every once in a while, we'll need to move towards a stem cell-based treatment, but for the most part, platelet-based procedures work quite well. And that's one of the differences you're going to see in Regenexx versus other clinics, meaning that, I see probably in the average month, let's say 20 patients with new back pain or more. And of those patients, I could move every single one of them towards a stem cell procedure, would certainly compensate me at around 3x for my time. But the reality is only about 2 to 3 in 10 will be appropriate for a stem cell procedure, and the other folks will do really well with platelet-based treatment. So that's one of the big differences you'll see at Regenexx is we're going to tend to offer you what's the least invasive, least expensive thing that's most likely to work, rather than the thing that reimburses us the best. And that's the way it should be.
And it's important to understand the reason for that, and that is because when you're in the traditional system, you sort of have your fully enclosed system, right? You are connected to your insurance provider, the employer, and the hospital and the doctors. It's all self-contained. So it seems like that's the easiest route to go. And in some cases, depending on your hospital systems, doctors are actually by contract not allowed to make recommendations outside of the things that their system offers. Now, that's important for you to be aware of because there's no insurance company I have seen yet that is willing to say, we're putting patients' health as our number one top priority over their legal obligations, number one, to their stockholders. By law, they have a fiduciary responsibility to basically make sure they are earning enough profit to take care of their stockholders first. Second, they've got to get doctors on board, so they've got to make sure they're paying doctors well and best, otherwise they won't be part of that system. And unfortunately, people's health is lower on that totem pole than those two other things. So doctors then sort of get into this place they can't afford to not be part of the system. So they get into it and they do what they've got to do by contract to make a living, pay back student loans, put food on the table, a nice house and vacations for their family who have so patiently waited through this hazing process of education to become a doctor. You, on the other hand, come from a different place. And so where I'm going with that is the money spent on advertising with the pharmaceutical support, all of those large dollars allow for that maximum exposure very much through advertising. When you see hospital advertisements, billboards, television commercials, when you see pharmaceutical advertisements on television constantly telling you, ask your doctor, that's the money machine in motion. And so they keep encouraging more people to come. Now, the Centeno Schultz Clinic is independent of that. They don't get the same kind of big pharma money. They say, no, thank you. We put patients first. Now, I know that's hard for most people to even fathom. Like, what do you mean? I go to the hospital. Don't they have my best interest at heart? Somewhere along the lines they do, but they can't if they can't continue to pay for those large buildings, if they can't continue to support the staff, the marketing, and all that goes along with it. So you've got to take a moment, pause, and think about how this whole thing is structured. And when you do think about it, you'll find that those doctors that are brave enough to tell the truth, hey, you know what? You don't need this really expensive one. You can actually get by with a much less invasive and much less expensive procedure. That sounds so foreign to most people that there's almost some degree of suspect or skepticism that that could be true, because that's not what the money machine is saying. Um, how do you explain the differences and why some doctors just fall into, the follow the money machine, and other doctors like yourself are really, I think of it as brave enough to be able to sort of stand up and say, I know everybody's going that direction, but we're actually in the other direction, and here's why. What makes a doctor like you go that direction, and more importantly, what do people need to know to really kind of understand that that's a reality of today's system?
Yeah, so listen, I think that, and obviously it's not just our clinic. There are other clinics out there that are both within the Regenexx network and outside of the Regenexx network that made the decision that they were going to start heading a different direction. And in medicine, that's a difficult thing to do, because when you leave that warm safety blanket of insurance, it's tough. It's financially scary. It's difficult to do. It's hard to reset up your practice to figure that out. It's just so much easier as a physician to keep that warm safety blanket of insurance coverage, because you just hang up your shingle, and as long as you're associated with the right hospital, and maybe that hospital buys your practice at some point, internalizes you in this humongous machine, then if you just stay there and do what you're supposed to do, you'll have lots of patients and someone else pays the bills. The downside of that is that you buy a lot of baggage by doing that. So the baggage that you're buying is literally that, I've got to do things a certain way. As an example, within the Regenexx network, I'm the medical director there, so I deal with physicians who are a part of large hospital systems, some of whom have tried for 2 and 3 and 4 years to add simple regenerative medicine treatments like PRP, and they've been told by their large hospital system again, nope, can't do it, nope, can't do it, nope, can't do it. So it's very difficult to leave that warm safety blanket. But once you do, the nice part about it is you get to do what you want to do. You get to really focus on, hey, what's the best thing I could do for the patient here? Not what's covered, but what's the best thing I know that might help this guy? Meaning, if it were me, or if it were my kid, or if it were my wife or my mother, what would I recommend for that person versus what I would not recommend because it's, quote, covered. And that's really the freedom that you get when you move outside that system. And it's not just within regenerative medicine. We've seen other doctors do that. Integrative physicians have done it because they just get tired of prescribing the same medications over and over to the same people that they know have serious side effects. So it's not only on the interventional orthobiologic side, which is what we do. It's also throughout medicine. You see doctors increasingly punching out because otherwise they get burnt out, and eventually that burnout will make them retire and move on.
Happens very much with chiropractors as well. It's a fine line. Some fight to stay in the system, get more reimbursement, then they get a taste of that comfort. And the next thing you know, they're ratcheting down the amount of visits people have access to, and so on. And at some point, as a doctor, you say to yourself, wait, who am I working for? Am I working for the people who I'm serving, or am I working for that insurance company to keep on paying me? And we bring this up basically not to confuse you, but to enlighten you. You've got the power means that you got to make the choice, and a non choice is a choice. In other words, I'm just going to go where it's covered, where my insurance is going to take care of it, is at the expense of oftentimes working with a doctor who has taken the time and taken the stand to say, I'm not working for the insurance company as my boss. I'm working for people as my boss. And I'm going to run my practice. I'm going to run my business based on the service I provide and the outcomes I get with people, because you will not see massive advertising campaigns by Centeno, Schultz, Regenexx, or anyone else, because most people come through referral. Why? Because our focus is on serving you, on getting you the best results at the best price available. And then they even have programs like, we call it our proactive program, for people that actually want to protect their investments, because you understand that your body is your responsibility and that no insurance company is going to make you their top priority. That's up to you. So if you don't think it makes sense to, shoot a cannon to kill a fly, and you'd rather go for the right approach for the right concern, then this is the conversation you want to have. I'm going to kick back to some questions over here. We've got another pre-submitted question by Henry. Henry says, submitted Henry Freeman says, will something bad happen if you just don't treat a disc bulge? You definitely don't want surgery. So what would be the recommended treatment, would you say, for most people most of the time with a disc bulge, if you want to avoid surgery, Doc?
Yeah, well, what we do for patients is to treat, realize a disc bulge happens because of a degenerative disc. Degenerative disc means that the disc starts getting the whole functional spinal unit there, meaning the disc, the two joints, everything that moves at that level starts to get sloppy. And so one of the ways to get it unsloppy would be to get the muscles online again. Some of that's physical therapy, some of that's injections to calm down the irritated nerve. We can inject some platelet lysate around that nerve, which in our experience does that. And then treat the irritated or banged up joints at that level and tighten down the ligaments. So that's really what we recommend. As far as leaving it there and not leaving it there, realize the only way to sort of quote get rid of it is to take out a part of that back wall, which is then going to make the disc weaker. So we generally don't recommend that unless there's a huge pressing reason to do it. That means that someone has tried these orthobiologic injections and for some reason we can't get them where they want to go. So again, it's not that there's nobody out there that needs that surgery. It's just that that surgery is done far, far too often in our experience.
Most surgeries are done way too often, and that's why it's important to pay attention to what's going on. Let's move back to Andrew has a follow-up. He says, yes, I've got an appointment with Dr. Kramberg next week. I've spoken with a number of top doctors in New York City regarding regenerative medicine, and it is clear that Regenexx is just on another level. This whole system is shocking to Andrew. It's shocking to me as someone in the system. Both on the doctor's side, I've been a patient, I've been a doctor, I've seen it from all sides, I've trained through it, as have you. And it is shocking. It is truly almost unbelievable. I mean, there's plenty of people, friends, family members, coworkers, previous and past patients, who, when they hear this kind of, conversation, it just doesn't compute that this could be this profit driven, this financially motivated. Maybe speak to the sort of idea that it's very common for this all to be sort of under the banner of science. The reason we're doing this is because the science says. And there's this whole sense, I'll even call it, I think of it as the Hippocratic oath more than the Hippocratic oath. And that is that if a non-medical doctor is going to do it, it has to stand up to the scrutiny of double-blind studies and meta-studies in order for me to believe that it's true. However, as hypocritical as it may seem, I, as a medical doctor, now I'm not a medical doctor might say to themselves, well, this was recommended by many of my medical colleagues. No, it doesn't have that double-blind high level of research behind it. But wink, wink, nod, nod, let's do it because it's popular and it pays well. Do you care to expose some light on what very few on the outside know that everybody in medicine does know?
Yeah, listen, it's always great to have research. You know, we publish a lot of research at Regenexx. We continually are looking for ways to improve the research base in regenerative medicine. There are others out there that are constantly working to do the same. Uh, at the same time, we have, a system on the surgical side which doesn't have much research support. So we have very little research that shows that doing anything surgically to that disc will help you. In fact, we've got studies that show that 3 or 4 years down the road, there's no difference between people who got that surgery and who didn't get that surgery. Same thing with fusion. If they decide to add hardware and fuse you, we don't have any pressing evidence that shows that fusion works all that well versus not doing it. So yes, there is a little bit of a double standard there between physicians who will, on the one hand, crow about we need as much research as humanly possible. We need double-blind, randomized placebo-controlled studies before we want to do anything. And then on the other side, who don't have that research to support what they do. And regrettably, in the surgical disciplines, that is extremely common. 80% of all orthopedic surgery as it exists today, whether that's hips, backs, knees, ankles, shoulders, has no high-level research to support it works. 80%, 8 out of 10 things that we do. So yes, there is that problem out there. It's been out there for a long time. It is hypocritical, absolutely, and it can be maddening sometimes for sure.
For sure. For everybody involved, doctors and people and all that goes along with it. It's a messy system, but the way it changes when informed people take their power back and go, okay, let me approach this differently. And when there's enough of us that just don't follow the system the way it is, and it's a busted, broken system. I don't think anybody in America, as much as we like to pride ourselves on we're number one, can use any statistics that necessarily say that we are the best in our total healthcare system. There may be a few things that we're best at, but as a system, there are no statistics I've seen that can help us claim that mantle. Let's get back to more questions. Hillary, also regular viewer. Hello, Hillary. She says or asks, hey guys, can lower back disc herniations with nerve impingement mimic occult tethered cord syndromes and vice versa? What is the best way to exclude either condition when they both could be present?
Tethered cord, just that everyone understands, you've got a brain up here, you've got a spinal cord that comes down, and a tethered cord can mean that the spinal cord is just too tight. You know, we have nerves that need to be able to move with our extremities, and sometimes it's pretty enough movement in the spinal cord, and it can sort of get tethered, which can irritate those nerves. Now, the problem with very hard to tell a tethered cord, especially in the realm of what we're talking about here, from just an irritated nerve in the back. And so there is no real test that can be done that says, aha, this one's a tethered cord, and that one's just an irritated nerve in the back. So that's the problem. And really, it comes down to a clinical diagnosis. If you treat an irritated nerve in the back, and it for the most part gets better, it's not a tethered cord by definition. If it were a tethered cord, you'd treat that irritated nerve, might get better for a couple days or something like that, and then it's all right back to where it used to be. So that's really the way to tell the difference, because we don't have good research that shows that, you know, this is the way via imaging or some other test to firmly diagnose a tethered cord, especially when it's like this. Now, there are types of tethered cords that are super duper severe, usually in kids with congenital problems, but that's a different story than what we're talking about here.
Hillary brings up a great point here, maybe worth sort of pausing and discussing a bit, which is what's your experience or what does the science say about the accuracy of most diagnoses? So, person goes into the doctor, doctor gives them a diagnosis. Um, do you have research or know of research that sort of indicates the probability of that diagnosis being accurate versus inaccurate? And I ask that because when people get an inaccurate diagnosis, they're now down the pathway of inaccurate care or inappropriate care if they don't get that diagnosis right. So let me start with that question. Your thoughts on the accuracy of most diagnosis?
Yeah, listen, diagnosis is the increase in accuracy of diagnosis is directly related to the amount of time that you take in coming up with the diagnosis and ruling other things out. And also, there's a heavy dose of experience thrown in there. Now, the problem is that in our insurance-based system, we have situations where doctors, just to be able to pay the light bill, are forced to see 30, 40, 50 patients in a day. They're forced to use, legions of physician extenders, PAs, nurse practitioners, just to make it all work, because it's impossible pretty much to see 40, 50 patients a day as a doctor unless you've got an army of people helping you. And the problem with that is each person gets less and less time. And as they get less and less time, the accuracy of diagnosis goes down and down and down. So that's the issue. So how many patients do we see in our clinic, which is all I can comment on, that have an inaccurate diagnosis? Probably half. Half of the patients we see and spend more time with have been given an accurate diagnosis that will lead to the wrong medical care. And it's not because the doctors they saw weren't great. It's not because this guy isn't the chairman of that, or works with this team or that team, or he's a famous doctor in his own right. It just comes down to time. Having the time to spend with patients. Now, we set our practice up that way, meaning there isn't a day that I ever see more than 12 patients. And that's important to me because it's pretty much impossible to do a good job if that got amplified to 30 or 40. My ability to help people and to come up with the right diagnosis, if I was seeing 40 patients a day, would be dramatically hampered because you don't have the time to really understand what's happening.
That's all perfect in most cases, but let's also just enlighten people to understand that diagnosis is not a computer algorithm where you can continually and consistently, put data in and have a consistent reply or answer. And I say that because a diagnosis by a doctor is ultimately a judgment call, right? And so if it's a judgment call, and if you are being reimbursed by a third party and you've got to make a judgment call, now, even in the best of cases, if it's 49, 51% on your judgment call, it's really easy to lean towards worse, as you said earlier, as opposed to more conservative because of the increased reimbursement. So would it be accurate to say with both the limited time and the financial incentive to also go, well, if I put this diagnosis code, I'm going to get paid X. If I put this diagnosis code, I'm going to get paid Y. It is a judgment call. Which one should I do? Is it fair to say that they might err towards a more severe diagnosis?
Yeah, or maybe just a more invasive treatment given the same diagnosis.
Fair enough.
So listen, at the end
Yeah.
of the day, if you're popping through 30, 40 patients a day, there's very little time to make decisions. You make decisions and you're going to tend to err on the side of, what obviously provides more for the clinic. Because if you're seeing 30 patients a day, you're seeing 30 patients a day because the clinic numbers aren't working out real well. You're not seeing 30 patients a day because you just love seeing 30 patients a day. I can guarantee you there's no physician who says, hey, tomorrow book me 30 patients because with 15 I'm bored. They ain't doing that. They're seeing 30 patients a day because that's where the numbers work within their system. And so if you're making that compromise, it's not going to be a big stretch to make the next compromise, which is to say, well, this one pays this one pays that, I'm going with that one. So again, we see this all the time, and having the time to spend with patients can really dramatically improve that diagnostic accuracy, but it is a luxury that many physicians have not granted themselves. And it's important for patients to understand that if you are in a waiting room, or maybe not these days, but if you're seeing, patients being put through at a furious clip, and the amount of time that you have personally spent with a doctor is 5 minutes or less, find a new doctor.
That's essential. Let's put this all together. Listen, we take the time to give you all of this background information so you're empowered to make the right decisions. These things are complex, even if you're in the system. Doctors, support staff that get into the system are just shocked themselves. We're experts in it, and we still can't believe just how difficult it is to navigate the system through the economics of it, through finding the right providers, through knowing who to trust and knowing how to follow up, and really putting the patient or person at the center of the system. And that's why you really want to do your research to find clinics like the Centeno Schultz Clinic that really work around people as their priority, as opposed to insurance companies or any other agenda beyond putting people's health and their outcomes first. That's why we put together the registry, which is tracking the outcomes over the past 15 years so we can aggregate the positive results and be aware of and track those results so that you can count on knowing what works and what doesn't because of the data, not because of the flavor of the month, not because of what's going to pay the most. In many cases, it's the exact opposite. It's what works best based on the data. That's the philosophy. That's how it works. That's the business model, and we're going to keep it that way. Doc, you want to just sort of, as we close up, give people really a sense of if they want to take a next step, how easy it is to take a next step. You can either type the word HELP, H-E-L-P, down below, receive your free copy of the Spine Owner's Manual. You can call the phone number down below. If they do that, Doc, and they want to come on in, explain perhaps as we close the difference between a telehealth consultation, a live consultation, and just sort of the steps it takes to go from curious to client in no time fast.
Yeah, so obviously patients who are close can come into the clinic. But even then, we've got some patients because of COVID who are saying, no, I'd rather do a telehealth visit. Obviously, if you're far away, telehealth can be a great place to start. What does telehealth mean? That means basically that we'll get on in a computer link with you just like this. We'll review your imaging, your history, and can actually get that covered now through most insurance plans, which wasn't the case in early March. So that's dramatically changed in a couple months. And we can now, because of the way the laws changed with COVID, we can now make diagnoses across state lines. So while we're licensed in Colorado, if you're in New York or Florida, we can make a diagnosis and order. We can see you back over the same telemedicine, view that imaging with you, and then make some decision for treatment. So it really has dramatically changed how we interact with patients. And it's also really improved things quite a bit for patients, because it used to be that we'd get on a telephone call with a patient if they were far away, we'd determine their candidacy, and then maybe, after discussion, we'd say, okay, you're a good candidate, come out. But what we can do now before they have to come out is dramatically expanded and improved.
That's fantastic. So if you've got questions, you can join us here on Mondays and Fridays. We've taken our Wednesdays. We're talking COVID on Wednesdays. You can join us at covidfactfiction.com on Wednesdays to sign up for notifications on that. And otherwise, we're here at your service, giving you the power you need to make the right decisions when it comes to your orthopedic conditions. If you're looking for the best results at the best price with the best doctors, then you want to reach out and learn more about your condition. Make sure you've got an accurate diagnosis with a doctor who will invest the time with you to help you understand what's going on, what you need to do about it, and the best price, the best value you're able to get that procedure done, often at less cost than even your covered service. As your deductibles get higher, your co-payments get higher, as less and less things covered, therefore more and more things are billed to you, surprise, then the more you realize that you can get the best results at the best price with the least amount of complications, and I'll even dare say risk, by checking out what is happening at the Centeno Schultz Clinic. And as we close, I'll remind everybody and even ask everybody to understand that, again, most people discover the Centeno Schultz Clinic through referral. That means people like you who are watching this program, who have had procedures, who have been following our program, who have worked with the doctors at the Centeno Schultz Clinic go, I get it, I understand. I'm going to help my friends and family know where to go, because you will not see our television advertisements interrupting your favorite shows and sports. You will not see our ads everywhere blanketing, wasting, spending money. Basically, your money, insurance money, gets spent on marketing. It's just not the way it's supposed to be in medicine. Good medicine means that good people get great results and share it with their friends. And that's what I'll leave you with today. When it comes to healthcare services, when you find a doctor you can trust, a doctor who can answer your questions, a doctor who can help you get the right diagnosis and therefore right treatment, then it really is incumbent upon you to share that with your friends and family. That's how people learn about the best places and people they should go to. Dr. Google doesn't work with who's best. Dr. Google works with who's willing to pay the most to get in front of your eyeballs. So do your friends and family a favor by sparing them the chase, by sparing them the journey, and letting them know that if they've got health concerns, if they've got musculoskeletal concerns, orthopedic concerns, whether it's early or late in the phase, find out if there's a natural approach to help yourself heal your body naturally. Help is available. Just got to reach out and ask for it. You can do that again by typing the word help down below, or calling our phone number you'll see up in our comments section. Dr. Centeno, thank you for taking the time, making the time, investing the time, and really helping people understand what they can and should do for themselves, do for their friends and families, to be able to get back to the life they were born to lead. Get that pain out of your life. Start living the life you know you should have. Age gracefully. Feel better. Till Friday, on behalf of Dr. Chris Centeno, I'm Dr. Jason Deitch. Stay well. Be kind. Thanks for joining us.